Hi, I'm Andrew Sharp. I'm a consultant cardiologist from Cardiff in the United Kingdom. I'm here at EuroPCR 2024. It's my great pleasure to be with Dr. Valérie Duchatelle from Sion in Switzerland, formerly of Paris, where we are right now. Valérie, we're going to talk about renal denervation here. So we're going to focus in this interview about setting up a service. So there are many aspects to this. I know you've just recently applied for ESH Centre of Excellence. You've got a multimodal team feeding into your service. Tell me, if people don't have that sort of experience Centre of Excellence already, how do they go about setting up a service for an RDN program?
So setting up our center took many years. What you really need to understand is always the first step is the harder one. You need to find a partner. It could be the nephrology department, internal medicine, other specialists around your institution or in your institution if you're in a large hospital. And as your team and expertise will build up, probably other specialists will jump in. Now we also have pneumologists coming in to comment on the sleep lab results for some patients, endocrinologists if we need them. So slowly the team has built up, but the anchor point, the cornerstone, I would say, was me and a nephrologist meeting up, discussing the first patient, and then slowly expanding the team.
So finding those people who are already seeing hypertension patients, you're an interventional cardiologist like me, and trying to bring them in, trying to identify what sort of patient you want to see. So what sort of patients do you want to be referred at the beginning of your program?
So we kept a very open mind because our purpose was to serve the population and to have as many patients as we could. So any complex hypertensive patient could be referred. It could be a young person that wanted or that had to be screened for a secondary cause. It could be someone with true resistant hypertension or someone with pseudo-resistant hypertension with multiple cardiovascular risk factors that had to be controlled. And we try to serve them in the way that we will rule out causes for secondary causes, establish true resistant hypertension, but also control other risk factors and offer a global project for the physician and for the patient.
Yeah, you've got this very innovative hypertension day that I really enjoyed hearing about today. So you don't just focus on case selection for RDN. You have RDN as part of a program that addresses everything. So tell us about your hypertension day.
Yeah, so Hypertension Day, the concept grew up from, it is so hard to collect results in lots of different places, sleep lab, sleep recording, lab works, ECG, echocardiogram. So the patient will come in one day and he will go through different stages. On the to-do list that day, there is obviously lab works, ECG, but also a nurse's lecture on diet and lifestyle and medication, and then a dietitian's workshop with their partner in the afternoon to reduce their salt intake. They will go for cardiac ultrasound. They will go home with the sleep recorder for sleep apnea. So the point is the patient only comes for one day and he gets fully investigated and educated at the same time. And this is a concept that was very performant in convincing referring physicians that we are not going to steal their patients. We're going to answer all their questions in one day. Then we'll discuss the results from all these tests, and it's easy to get the results because they're all done in the same place. And then we return to the patient and their physician with a very concrete proposition.
So this is a key part of an RDN service, is involve these key stakeholders in your own center, reach out as a group, offer a good service, make the patients feel valued and the referrers feel they're going to get a good service. And then once you've completed that service, send the patient back if the referrer would like that.
Absolutely.
So what are the follow-up arrangements? So you've seen a patient, they have resistant hypertension, you've done your ambulatory, you've excluded secondary causes, you take them to the lab, you denervate them. How do you then follow up your patients?
That will depend mostly on their kidney function. If they have chronic kidney disease, then the nephrologist will carry on the follow-up according to the guidelines, according to the stage of their renal failure. If they don't have renal failure and they just hypertensive or high-risk patients, they will be returned to their usual cardiologist, as it was important for us not to steal patients from referring physicians, but this is the local habits. It might be different depending where you live, because if you are lacking specialists, maybe you will want to schedule follow-ups.
Yes.
What we do ask for though is for the limited number of patients that will go through renal denervation, we want a 1-year follow-up just to get a letter from the physician with the blood pressure monitoring, ideally a 24-hour blood pressure monitoring at home, so that we can put it in the database and then analyze our own results.
Okay, so if I can summarize, you form allies, you build a team, you reach out, you offer a great service, you look after your patients really well, you denervate them, you check they're okay, and then if your referrers would like to carry on the follow-up, that's great, but you'll keep in touch from a distance, make sure you've got long-term follow-up.
Yeah, basically what we offer is a service, so we'll adapt. If someone wants us to follow up patients, or if they want to see us a year for a 1-year follow-up because they have bounded to us, or we've built trust, or they've developed coronary disease and they want to have an interventional cardiologist as their referring cardiologist, of course we'll offer that service. But very often we just offer a punctual help, and we really just try to match the demand. I think the success comes from that. We are providing a service, and we're creating a win-win situation with our partners.
That's great. So thank you very much for watching and listening. This is what I would call the gold standard of RDN. But if you're in your center, find allies, reach out for patients, give them a good service. Thanks very much.